Good afternoon, everyone. My name is Amy Smollers, and I'm Senior Director of Healthcare Education and Professional Development at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Medicare Advantage, What's Around the Corner in 2025. A few logistics before we start. If you have questions, please put them into the chat feature as we are in listen-only mode today. The questions will come directly to us, and we will do our best to get them addressed during our time together and or at the end of the presentation today. I also want to take a moment to thank MHA's 2024 annual sponsors, as well as our strategic partners, for their support in underwriting today's webinar, which is just one of many events that we offer throughout the year to connect our members with leading experts to help address timely issues like the one we have today. I'm now pleased to introduce our speakers from Robinson & Cole, Kathleen Healy, and Michael Lisitano. Kate is a partner at Robinson & Cole who specializes in healthcare regulations, advising a broad range of clients from health systems to digital health providers. She is part of Robinson & Cole's health law, healthcare industry, and data privacy and cybersecurity teams. Mike is an associate at Robinson & Cole who represents hospitals, health systems, and physician groups on corporate and health law matters. He advises on regulatory issues including HIPAA, Medicare and Medicaid compliance, as well as state laws. So thank you both for being here today, and I'd love to hand it over to you.
Great. Thank you to Amy, and also thank you to the MHA. Mike and I are pleased to be with you this afternoon. We're going to cover Medicare Advantage and particularly the changes for 2025. So next slide, please. And next slide, please. Today, we're going to focus on covering the changes to Medicare Advantage that have been announced and finalized by CMS. And we'll first cover the rate changes that were announced in the 2025 Medicare Advantage Advance Notice, as well as the 2025 Medicare Advantage announcement of capitation rates. Then we'll turn and talk to and about the policy and technical changes that were announced by CMS through the calendar year 2025 final rule. So with that, I'm going to turn it over to Mike.
Thank you, Kate. And if you could go to the next slide, please. All right. So we could start with a little bit of background on the rates. So each year, CMS is required to update Medicare Advantage payment rates and regularly makes technical updates as well in the form of improvements needed to keep Medicare Advantage payments up to date and accurate. CMS does this annually by releasing an advanced notice and a final rate announcement for Medicare Advantage, which generally includes Medicare Part D prescription drug benefit updates as well, which of course are not the subject of today's presentation. So we'll be focusing on these documents' changes to Part C rates. The advance notice is issued first, and it's intended to really do just that. It provides stakeholders with advance notice of the coming changes. It was issued on January 1st of this year, and CMS accepts comments to comply with its notice and comment rulemaking requirements. For all of the non-lawyers here, notice and comment rulemaking is a requirement in certain circumstances for federal agencies to promulgate rules under the Administrative Procedures Act. CMS then takes these comments and considers them and responds to some and issues what's called the final announcement. This contains finalized updates and also incorporates anything from the advance notice that's not expressly changed or excluded. CMS issued the announcement on April 1st of this year, and the changes are effective for January 1st of 2025. Next slide, please. So what exactly are the rate changes for 2025? This slide includes a screenshot of a chart from the announcement detailing the payment changes and how exactly they're calculated. You'll note that there's two columns with different data. The first is the proposed rate changes of the advance notice, and the second are the finalized rate changes of the announcement. There is some minor variation between the two, and we'll discuss what each of those are and what each of the factors in this calculation are as well. The big takeaway, however, is that CMS is projecting a 3.7% increase in payments made to Medicare Advantage plans. This is about a $16 billion increase from last year and will bring total projected Medicare Advantage expenditures to between $500 and $600 billion for 2025. There's a recent notable trend here, as in recent years, the majority of Medicare beneficiaries are now enrolled in Medicare Advantage, and Medicare Advantage spending on Part A and Part B benefits actually exceeded Part A and Part B benefit spending for beneficiaries in traditional Medicare. Providers should really be aware of this as they're negotiating with Medicare Advantage plans for reimbursement, as it represents a growing portion of the federal healthcare programs, and CMS is seeing increased spending accordingly. So next slide, please. So let's move on to how the 3.7% effective rate increase is calculated. The first line item in the chart is the effective growth rate, which is a current estimate of growth rate benchmarks and is really largely driven by Medicare fee-for-service per capita costs. It's calculated based on historical data, and the reason you see a change here from the advance notice to the announcement is because CMS had more historical data from Q4 of 2023 to utilize that wasn't yet available on January 1st when the advance notice was issued. Importantly, in last year's 2024 announcement, so this would be for the current calendar year issued in 2023, CMS proposed a new methodology for calculating the growth rate, which was to be phased in over multiple years. So for 2025, 52% of the growth rate will be calculated using the new adjustment and the remaining 48% with the prior methodology. The change in these methodologies is really a technical adjustment, removing Medicare Advantage related indirect medical education and direct graduate medical education costs from the historical and projected expenditures data. So with that removed, there will be some variation in the historical data. Biggest takeaway here from this is that CMS is projecting an increase in Medicare fee-for-service costs over the next year. Next slide, please. So the next factors in the chart are rebasing and changes to star ratings. Rebasing refers to a process of updating county base rates for Medicare. The purpose of rebasing is to update the rates based on CMS's latest estimates of spending variations for each county. Rebasing, or it's sometimes referred to as repricing impact, is dependent on finalization of something called the AGA, the Average Geographic Adjustment Index, which was not available with the publication of the 2025 advance notice, hence why it's to be determined in the chart. The average geographic adjustment is based on a 5-year average of fee-for-service Medicare spending in specific counties. And notably, this was a point of a bit of contention and comments on the advance notice from stakeholders as they pushed back on the methodology, given that a 5-year period would include data from the COVID-19 pandemic timeframe. CMS ultimately responded to these comments, but did not incorporate any proposed changes based on a belief that utilizing 5 years of data is really designed to even out any fluctuations, as well as noting that ultimately this is an average. So that data will include years from the COVID-19 pandemic. Then the star rating changes. So this reflects an estimated effect of changes in quality bonus payments for the upcoming payment year related to Medicare plan star ratings. These are actually calculated based on 2022 quality data for the 2024 star year, and importantly indicates an overall aggregate drop in star ratings. So later on, we'll be discussing some policy changes to how exactly the star ratings are determined. But for rate determination purposes, it's important to note that quality payments are expected to decrease. Next slide, please. So the next factors are the risk adjustments. In calculating expected spending, CMS applies risk adjustment metrics, and these are really intended to make sure that payments are fair and accurate and reflect the health status of patients being served. Essentially, CMS is paying more for patients who have more chronic health problems and less for patients that are healthy and requiring less services. In 2024, CMS proposed changes to the risk adjustment model, similarly to how they proposed changes to the growth rate model. The changes were a restructuring of condition categories. They are now going to utilize the ICD-10 classification system instead of the ICD-9 classification system, which they were using in years past, and are updating the data years that are going to be looked at for calculating. So for 2025, CMS is going to use a phased-in approach of the new 2024 model. They're going to do this by blending the risk score. So 67% will be calculated utilizing the 2024 model, and the remaining 33% will be calculated using the old model. Altogether, this will result in a 2.45% savings, or a reduction of about $9.2 billion in spending from the Medicare Trust Fund in 2025. So these are going to be reductions in what gets paid out to Medicare Advantage plans. Next slide, please. The final factor is the Medicare Advantage risk score trend. So CMS calculates the risk score trend by taking Medicare Advantage risk scores over the prior 3 years and calculating an annual average change across the 3 years. This number does not account for normalization and coding pattern adjustments. Those are shown in separate rows of the chart, and that's the reduction that we discussed on the last slide. So CMS breaks these out for transparency, instead of including them as a single risk number, so it can be seen where the reduction is coming from and where the increase is coming from. The risk score trend will vary based on several factors, including changes to demographics and coding patterns. All 3 years of risk scores are calculated under both the new 2024 model as well as the old model, and then are blended again as part of the phase-in of this 2024 model. So the risk score trend for the 2024 model was a 3.3% increase and 5% under the old model. Again, using this blended rate allocation of 67% to the new model and 33% to the old model, the blended Medicare Advantage risk score for 2025 is 3.86%. So altogether, those line items are ultimately what result in the 3.7% expected increase in spending with Medicare Advantage plans. Next slide, please. So the final change in the announcement is how the Part C star ratings are calculated. As previously mentioned, the Part C star ratings affect quality bonus payments, and there were also some policy changes made in addition to the fact that there's an anticipated decrease in spending. The Part C star ratings policy changes were included in the announcement, of course, because of this financial impact that they have. They're designed to reflect the experiences of beneficiaries with Medicare Advantage plans, assist beneficiaries in finding plans for their needs, and determine eligibility for the bonus payments. CMS is making a variety of changes to how these are calculated, particularly by updating care coordination metrics in the form of patient questions focused on how often doctors, nurses, or healthcare providers are explaining the results of tests. Notably, these are star ratings for plans, not providers, unlike, for example, the CMS nursing home star ratings. So even though these are plan-focused, as you'll note with the change and asking questions related to discussions with providers, Medicare Advantage plans are likely to negotiate quality incentives and metrics in reimbursement agreements with providers that help them to ultimately obtain quality bonus payments. So providers should really be aware of what's driving those changes in metrics in those negotiations. And that concludes the summary of changes in the advance notice and the announcement. So I will turn it over to my colleague Kate to discuss some policy changes from the final rule.
Thanks, Mike, and thanks for advancing the slide. So now we're going to turn to the final rule policy and technical changes. And just as a reminder or a recap, the advance notice was issued on January 31st of 2024, and the announcement which published the rate changes for calendar year 2025 was issued on April 1st of 2024. The final rule was actually issued on April 23rd of 2024 and went into effect on June 3rd of 2024 for calendar year 2025. And just to introduce the overarching policy rationale for the 2025 changes that we'll discuss is to strengthen protections for enrollees and establish some better guardrails on Medicare Advantage organizations and professionals. They're also intended to promote healthy competition and to ensure that Medicare Advantage plans best meet the needs of enrollees. Next slide, please. So the first change that we're going to talk about is something that I think is welcome to all of us in the healthcare provider community, as well as all of us in the healthcare consumer community. And that is there's an emphasis on improving access to behavioral healthcare providers for enrollees. In the final rule, CMS took steps to improve access to behavioral healthcare services for enrollees by providing important updates to the network adequacy standards. The policy rationale for the changes is to improve enrollee access to behavioral health services. It's worth just thinking for a minute about the background. In the Consolidated Appropriations Act of 2023, CMS established a new statutory Medicare benefit category for services performed by marriage and family therapists and mental health counselors. To improve enrollee access to behavioral health providers, CMS is now adding network adequacy standards for a new health facility specialty provider category to include a range of behavioral health providers, and those include marriage and family therapists, mental health counselors, opioid treatment providers, program providers, community mental health centers or other behavioral health and addiction medicine specialists, nurse practitioners, physician assistants, and clinical nursing specialists. CMS also addressed current concerns from commentators that some NPs, PAs, and clinical nursing specialists might lack the necessary skills and training or expertise to effectively address the behavioral health needs of enrollees. By adding specific criteria that Medicare organizations must use to determine when an NP, PA, or CNS can be included in the outpatient behavioral health category to meet the new network adequacy standards for outpatient behavioral health. Specifically, the Medicare Advantage plans must independently verify that the provider they are adding to their network has furnished or will furnish services to at least 20 patients within a 12-month period using reliable information about services furnished by the provider, such as the Medicare Advantage plans, claims data, prescription drug claims data, electronic health records, or similar data to make this determination. I think it's just worth noting for all of you who work with providers that some of these requirements may spill down to you in the provider community to help give the plans the evidence that they're looking for with respect to the experience of these new providers. In addition, while evaluating a Medicare Advantage organization's network, CMS is adding this outpatient behavioral health facility specialty to the list of specialty types that will receive a 10% credit toward meeting required time and distance standards. The Medicare Advantage organization's contracted network of providers must include one or more telehealth providers of that specialty type who provide additional telehealth benefits or covered services. Next slide, please. So now we're getting into a guardrail that's been added in the new final rule. And just by way of background, many individuals with Medicare rely on agents or brokers, this is particularly for Medicare Advantage, to help them navigate complex Medicare choices as they comparison shop for coverage options. The policy rationale for these changes is to ensure that the agent broker compensation incentives are designed to encourage agents to enroll individuals in plans that best suit their needs. The Medicare statute requires CMS to establish guidelines to ensure that the use of compensation creates incentives for agents and brokers to enroll individuals in the Medicare Advantage or Part D plan intended to best meet the prospective enrollee's healthcare needs. However, excessive compensation and other bonus arrangements offered by plans to agents and brokers can result in the individuals being steered to some Medicare Advantage and Part D plans over others based on the agent or broker's financial interests rather than the prospective enrollee's healthcare needs. That's what CMS is cracking down on. Specifically, CMS is finalizing requirements that redefine compensation to set a clear fixed amount that agents and brokers can be paid regardless of the plan in which the individual enrolls. The final rule also prohibits certain contract terms between Medicare Advantage organizations and Part D sponsors and middleman third-party marketing organizations that create incentives to inhibit an agent or broker's ability to objectively assess and recommend the plan that's best suited to a potential enrollee's needs. Examples in the final rule include volume-based payments to agents and brokers. Next slide, please. Next, we're going to talk about the changes to special supplemental benefits for the chronically ill. And just by way of background, the Bipartisan Budget Act of 2018 authorized Medicare Advantage plans to cover new special supplemental benefits for the chronically ill. The policy rationale for the 2025 change is to ensure that SSBs, as they're referred to, are reasonably expected to improve the health or safety of the chronically ill. So what are SSBIs? They are the benefits that are provided only to eligible chronically ill enrollees, and the benefits are required to have a reasonable expectation of improving or maintaining the overall health or function of the enrollee. Here, CMS is concerned that plans are offering frivolous BCIs, and using them to entice enrollees. So what are the new changes? The new requirements are that by the date the MAO submits a bid to CMS, the Medicare Advantage organization needs to establish a bibliography of relevant acceptable evidence that a particular item or service offered as an SSBCI has a reasonable expectation of improving or maintaining the health or overall function of a chronically ill enrollee. In addition, they require Medicare Advantage plans to follow written policies based on objective criteria for determining an enrollee's eligibility for special supplementary benefits for the chronically ill when making such eligibility determinations. They also require a Medicare Advantage plan to document both denials and approvals of SSBCI eligibility. In addition, the changes codify CMS's authority to review and deny approval of an MAO's bid if the MAO has not demonstrated through relevant acceptable evidence that the proposed SSBCI has a reasonable expectation of improving or maintaining the health or overall function of the chronically ill enrollee. And finally, the changes codify CMS's authority to review SSBCI offerings annually for compliance, considering the evidence available at the time. A few examples of SSBCIs include structural home modifications, non-medical transportation, food and produce, pest control, service dog support, and indoor air quality equipment and services. Next slide, please. There are also changes to utilization management committees in the final rule for 2025. The goal of the health equity analysis that's being introduced is to create additional transparency and identify disproportionate impacts of utilization management policies and procedures on enrollees who receive a low-income subsidy, who are dually eligible, or who have a disability. The policy rationale for the 2025 changes is to take steps to advance health equity. And so what is CMS doing? CMS is updating the composition and responsibilities for committees. And in particular, the final rule includes updated requirements to address health equity. CMS is now requiring at least one member of the committee to have expertise in health equity. In addition, the committee needs to conduct plan-level annual health equity analyses of prior authorization policies and procedures used by the Medicare Advantage plan. And the results of the analysis must be made publicly available on the plan's website. Next slide, please. Enrollees have also been granted an enhanced right to appeal in the 2025 rule. So just to back up, under traditional Medicare, enrollees have a right to fast-track appeal through an independent review entity when their covered skilled nursing facility, home health, or comprehensive outpatient rehabilitation facility services are being terminated. The policy rationale for the 2025 changes is to provide Medicare Advantage enrollees with the same access to fast-track appeals as enrollees in traditional Medicare. Quality improvement organizations address complaints about quality of care and review appeals for both original Medicare and Medicare Advantage when an enrollee disagrees with the provider's decision to end care. These changes are intended to bring Medicare Advantage plan regulations in line with the parallel reviews available to individuals under traditional Medicare and expand the rights of Medicare plan enrollees to access the fast-track appeals process. So the final rule makes the following changes. It requires the QIO, instead of the Medicare Advantage plan, to review untimely fast-track appeals of a Medicare Advantage plan's decision to terminate services in a skilled nursing facility, comprehensive outpatient rehabilitation facility, or by a home health agency. And it also eliminates the provision requiring forfeiture of an enrollee's right to appeal a termination of services from their providers, from the providers I mentioned, when they leave a facility. Next slide, please. Next, we're going to talk about the notice requirements for supplemental benefits that are introduced in the final rule. The policy rationale for the new notice requirements is to encourage Medicare Advantage enrollees to utilize supplemental benefits by providing them with a mid-year notice of their unused benefits. As background, an increasing share of Medicare dollars is going towards Medicare Advantage plan rebates. Some plans have reported that enrollee utilization in these supplemental benefits is low. The notice that is now going to be required will include a list of any supplemental benefits not accessed by the individual during the first 6 months of the year. In addition, the notification will include the scope of the benefit, cost sharing, and instructions on how to access the benefit, as well as any network application information for each available benefit, and a customer service number that enrollees can call if additional help is needed. The notice requirements are intended to advance President Biden's executive order in July of 2021 by helping to make consumers aware of their plan benefits, facilitating better decision-making and consumer choice in the Medicare Advantage market. Next slide, please. I'm going to touch briefly on the new Medicare Advantage risk adjustment data validation appeals process. It's somewhat technical, and it is, I think, directed at Medicare Advantage organizations, but it's worth mentioning to all of you that CMS made changes to the Medicare Advantage risk adjustment validation appeals process in order to accomplish a policy rationale of aligning what were inconsistent appeal adjudications. So CMS is finalizing revisions to the appeals process so that Medicare Advantage organizations will not request both a medical record review determination appeal and a payment error calculation appeal at the same time. MAOs that request a medical record review determination appeal may only request a payment error calculation appeal after the completion of the medical record review determination administrative RADV appeal process. And again, this was to require a delinking of the previous concurrent appeal process in an attempt to avoid inconsistent adjudications. Next slide, please. There are a few other changes that I wanted to just mention that are less notable for healthcare providers, but are still important. So it's worth noting that CMS affirmed its own authority to collect detailed information from Medicare Advantage organizations by broadening the reporting requirements of Medicare Advantage organizations, excuse me. It's also important to note that CMS is limiting the distribution of personal beneficiary data by third-party marketing organizations. And what's been going on is that some, they're referred to as TPMOs, have been selling and reselling personal beneficiary data, which can undermine existing rules that prohibit cold calling people with respect to Medicare Advantage and result in other aggressive marketing tactics for Medicare Advantage and Part D plans. To curtail this practice, in the final rule, CMS codifies the requirement that personal beneficiary data collected by a TPMO for marketing or enrolling the individual into a Medicare Advantage or Part D plan may only be shared with another TPMO when prior express written consent is given by the individual. Next slide, please. So what are the key takeaways for healthcare providers? The requirements and affirmative obligations of the advance notice, announcement, and final rule are generally targeted at Medicare Advantage organizations, but healthcare providers should be aware of these requirements as they will have an impact. The reimbursement contracting process with Medicare Advantage organizations, they will also impact care coordination priorities of Medicare Advantage organizations, as well as service lines where there's an opportunity for growth based on compensation enhancements from CMS. Finally, I think there are some common themes for healthcare providers to consider. In addition to the rate changes, which I think is a positive one for healthcare providers as well. I think it's important for the healthcare provider community to understand that CMS is increasing access to behavioral health providers. It's also implementing measures to advance health equity. CMS is evidencing that it values supplemental benefits and sees them as a means to address social determinants of health. They're also encouraging utilization of supplemental benefits. And in addition, CMS is implementing measures to protect enrollees from agent steering and cold calls by prohibiting third-party marketing organizations from selling patient information without enrollee consent. Questions. Next slide, please. I think we're at our question slide.
Hi, thank you both so much for that really thoughtful, insightful, and a lot of information for the presentation today. We do have one question that has come in the chat, and I'll read that. And also, it's one of those with full disclosure on the previous slide of some answers are very involved and deep and intricate. I think an email follow-up could work as well. But one of the first questions is, can the timeline of when these changes are effective, what exactly does that timeline look like in the rollout?
The general effective date for these changes is January 1st of 2025. So these changes are effective in 2025. Mike, is there anything you want to add?
Same thing for all the rate adjustments I was discussing is January 1st of 25.
Right, there's one other question that's here in the chat of having issues with post-acute care transitions being denied and not always consistent with traditional Medicare. Aside from working with CMS, is there anything else that can be done to escalate these issues, and any suggestions?
That's a great question. I think that's probably more of a policy issue, because that really won't be something that the provider community can directly influence in terms of making those appeals.
Great. And as we're getting, I promise there's another question here in the chat of, can you share what CMS is doing to ensure Massachusetts plans are following the final rule related to utilization management and the 2-midnight rule and meeting medical necessity? Is there, in addition to that, a follow-up? Is there auditing taking place?
Well, I think we're not aware of what exactly CMS's auditing priorities will be for 2025, because these changes are just going into effect in 2025. So I think that's difficult for us to discern. until these changes are actually in effect. I think it's also likely that CMS can't monitor compliance by health plans until the changes are in effect. So we're probably a little premature in terms of our ability to forecast where they will focus. I don't know, Mike, do you have thoughts on that?
No, I agree.
Great question, though.
No, there's a lot, and that's is, this is why we have these, right, to have this. And I think another question is can you share your thoughts on why some insurers seem to be dropping their Medicare Advantage plans?
I think some insurers are challenged to have Medicare Advantage plans really be profitable. I think it's a different reimbursement structure, and I think sometimes it's difficult for them to really succeed under that payment model. That's my thought. Mike, do you have other thoughts?
Yeah, I agree. I know we discussed a kind of a trend in increased spending, right, allocation on Medicare Advantage, but it is very geographic dependent, right? So there are many regions where the plans might make a lot more sense than they do in other regions. So some regions probably do not have the same success in implementing Medicare Advantage plans, hence why they might be trending away from them.
Very well. The last question, I would say there's so much information that you all shared today. Do you have, and it's hard to boil down, but one or two things that folks could take away or that you want to make sure people learn, understand, or have a resource to share with folks today?
I think one thing that I would just underscore, and I know I mentioned it in my my slides, is I'm really encouraged by CMS's emphasis on additional access to behavioral health care providers for Medicare Advantage enrollees. I think that's really a positive development for providers and for consumers. I am also really encouraged by CMS's emphasis and attempt to advance health equity. And I do think CMS is forecasting through these payment policies its appreciation for the important role of supplemental benefits like dental and vision care and food for Medicare Advantage enrollees. Mike, what would you add?
Yeah, just CMS does seem to be focusing on increased expenditures in this area. So there's certainly a focus on continuing to fund and expand the program. So in understanding that in negotiations with Medicare Advantage plans, I think is important.
Well, great. Well, on that note, thank you both so much for sharing your time and all of this information with us this afternoon. Really appreciate this. And we have additional programs coming up this fall, as well as additional webinars, and we have a healthcare safety balance prevention event just next week happening here at our Burlington Conference Center. So again, thank you both, and everyone have a great afternoon.
Thank you for joining us. Yes, slides will be shared.
Yes, slides and a recording will be shared.
Have a great afternoon, everyone. Thank you.
Thanks, everyone.